So I'm Bobby, one of the third-year R3s. Today I'm going to be presenting a B-Team conference. So we'll just start with the patient presentation. So here we have a 52-year-old female with a remote history of a Roux-en-Y gastric bypass and 20 years ago. We presented to the emergency department with 4 days of worsening, primarily epigastric, but diffuse abdominal pain, nausea, and vomiting. She described the pain as crampy. It was initially alleviated with passing gas, but hadn't passed gas for 24 hours and hasn't had a bowel movement in 2 days. And has progressed to the point where she can no longer tolerate PO intake. Her past medical history and surgical history is listed up there. Maria, given what you know about the patient, that they have a remote history of a Roux-en-Y gastric bypass, are there any other questions that you might think to ask in this patient? And then more broadly, what are kind of typical sort of post-operative complications that you want to be thinking about as you're walking to see the patient, which will kind of help tailor how you conduct that interview? Okay.
So I would ask about bloody bowel movements or short bowel movements.
Okay. What are certain risk factors that might contribute to the development of a marginal ulcer?
Smoking and not taking their PPI.
Good. There's one other medication that these patients should avoid for life. The type of medication. Okay. Yep. So make sure, because they'll tell you what meds they take, and then they'll skip over the fact that they've been overdosing on, or even just taking ibuprofen for some back pain. So you do want to make sure that you ask specifically about those types of things. Jamie, anything else? Any other kind of common or feared complications after Roux-en-Y?
I mean, in this particular situation, granted she had the surgery a while ago, you can still develop any kind of like slow anastomotic stricture obstruction.
Yep, sure. So she's presenting with obstructive type symptoms that could have to do with just sort of like an anatomic variance or complication, like a stricture that might develop from the GJ or the JJ pouch itself. What other kind of obstructive or obstruction type issues that can develop with people with this type of anatomy? Yeah, so that's one thing that you definitely want to think about. So this is just kind of a slide of just briefly an overview of somewhat of an exhaustive list of all the types of complications that can occur after Roux-en-Y gastric bypass. Some of these will show up in different kind of phases of the post-operative setting, whether it be the acute or long-term. Bleeding and a leak typically will occur in the more acute setting. PEs take a little more time to develop, usually around 4 to 6 weeks, but things that you always want to think of, and particularly the obese population, they're at higher risk, and particularly those who have had surgery as well. We discussed marginal ulcer, a GG fistula, classically on test taking scenarios and obviously in person. These patients could present with weight regain. They're effectively bypassing their bypass. A lot of times this can happen when after sort of ineffective transection or creation of the gastric pouch, sometime a small remnant can be left behind, or sort of connection between the GJ and the remnant stomach itself. And then obviously, like any other patient with a post-surgical history, those patients can develop adhesions, and then as we'll go a little more into, they can also develop internal hernias. And then there's also dumping syndrome, and then particularly nutritional and vitamin deficiencies are definitely things in both test taking scenarios and in real life where you really want to think about what types of Angie, do you know what types of nutritional deficiency that you worry about in these patients? Okay, and so do you know why that can occur? Yep, exactly. So issues with mixing with the intrinsic factor that's necessary for its absorption. Connor, any other kind of types of vitamins or nutrients that were about these patients becoming depleted? Okay, iron. Yep. primarily because, you know, bypass the duodenum, which is the primary site of absorption. Frank, any other ones that we really want to make sure? Yep. So, well, yes. Yes. Yeah. So you particularly want to, other questions that you should be asking are any neurologic symptoms, any difficulty walking, numbness or tingling, because these patients can develop Wernicke's encephalopathy, and that can be really devastating for the patient. That's why, as a part of our kind of bounce back or ER protocol for these bariatric patients, they get a banana bag, so they get infused with IV thiamine, and those labs should be getting checked regularly. And the gallstones, you know, these big patients, after rapid weight loss, you know, the gallstones can kind of crystallize and fall out of formation and create issues as well. So,
what about, like, you mentioned the factor of people, so what else about it? It's not, because I mean, the fungus is still up in place, right? So why is the factor, or why do people? Just because the fungus is separated from the mouth. What's the site of absorption?
I guess primarily the duodenum as well.
And the proximal. So
Okay.
that's the real issue, is that your B12 is going through the root limb and not through the proximal taking under.
Great, thank you. And then just for some of the junior residents, this is kind of a typical post-operative configuration of a Roux-en-Y gastric bypass. So you have the GJ right here. And there's a few different terminology that's used to describe some of these limbs of bowel. This is Zollinger's image, and these are kind of these are sort of the less commonly used. And so this is your biliopancreatic limb, or the BP limb, that will connect here at your JJ or jejunostomy site, which will then create the common channel, essentially where your roux or alimentary limb meets the BP limb. So these are just kind of common terminology that you might run into, and can sometimes be confusing. So in this patient, yeah.
So the anticolic versus the retrocolic roux, then does that change?
It does.
What you're thinking of in terms of possible obstruction? Is it more likely to be internal hernia?
It does, and I don't know that it increases your. Well, I mean, you create a new defect, and so I don't know. I'm not familiar with the data. I'm not sure if you're at elevated risk for developing an internal hernia, but you create a third defect, and we'll go into that anatomy in a little bit. But okay.
One of the reasons is one of the reasons.
If we sort of say next year, what we kind of call in this would be on this, when did we start seeing more anticolic?
So if it was back in the early 2000s, like before 2000, I don't remember the exact year, but before like 2005, most likely.
All right. So just further details on the patient. So this patient was, go down and evaluate her. She's afebrile, hemodynamically normal, on room air, sat fine. Her abdominal exam is notable for some diffuse distension. You note some prior abdominal scars. Again, she's had a chole and a tubal ligation. She's diffusely tender palpation and with some rebounding guarding in the left upper lower quadrant. So you're going to get some lab work. Again, particularly try to include, you want to include those vitamins specifically to ensure that there's no ongoing deficiency in place that you need to correct, and then proceed with a CT of the abdomen pelvis. And so this is a video of ours, and I'm going to try to show you some relevant aspects. So here, just coming down into the abdomen, you noted a diffusely sort of dilated GJ and roux limb. Moving down a little We're slowly here. Here's your following your root limb, diffusely dilated. You see a little free fluid, mesenteric stranding. Makes you concerned for a higher grade obstruction coming down in the pelvis. Coming back up. And a little bit of free fluid here, extending along the gutters. And then we're going to move to some coronals here in a second. Eventually. Okay, so just going back through. So here again, you'll see a diffusely dilated GJ. Here's your GJ anastomosis, dilated root limb. And then most notably, as you follow the SMA as it drops off the aorta, you'll see a swirl sign here. It's like a little hypnotic, moving back in time. But yeah, so those are some, essentially your mesenteric swirl sign is finding very classic, classically associated with an internal hernia, and should give you a very elevated suspicion that that's going on, and push you. I'll talk about some other radiographic findings in a minute. But so, anyways, this patient went to the OR, and that's what we found, internal hernia. But I'll talk about kind of just the generic management here thereafter. So again, in general, this is again your typical anatomy, basic sort of component. Ours, Peterson's defect, which I'll go into in 1 second. So again, when you're doing a gastric bypass, this is essentially your post-operative anatomy. You're creating a small gastric pouch, 15 to 30 cc's. Or you first start with a transection of the jejunum, including some of the mesentery here. You will then you'll measure 50. You'll go to the ligament trites, measure 50 centimeters, which is typically what you want your BP limb to be, and then march 100 centimeters further down the small bowel, down the jejunum, to create a root limb of generally around 100 centimeters, 150. That can be variable depending on how much weight loss or malabsorption, but is kind of typical practice, at least here. You'll then construct the JJ anastomosis in an isoperistaltic fashion to make sure that that bowel, that mesentery isn't twisted. You create a defect inherently in the mesentery with the creation of this JJ anastomosis that needs to be closed. And then you'll turn your attention up to the stomach, where you'll create this retrogastric tunnel, create the gastric pouch, and then construct that anastomosis that to the jejunum. And there are a variety of ways to do that with a linear or EEA stapler, even hand sewn. But so what that eventually does is it can create, depending on whether or not you go anticolic or retrocolic, you can have, if you go retrocolic, you will have a total of 3 different defects from which a internal hernia can occur. So the first is in your transverse mesocolon, the hole in which you create to be able to pass that jejunum, that sort of proximal root limb up to the gastric pouch. Essentially, it requires the advantages of that is essentially that root limb will be under less tension, requires less sort of mobilization. But again, a big major disadvantage, and as Dr. Marcel was just speaking to, this creates another defect through which internal hernias can pass, or through which the remainder of your small bowel can pass, and increases the chances of you having an internal hernia. B right here is classically known as Peterson's defect. This occurs between the mesentery of the root limb, or your jejunum right here, and the mesentery of the transverse of the mesocolon, of the transverse colon. This is routinely closed in the creation of the gastric bypass, and the procedure of a gastric bypass. And then there's a JJ defect as well. And so just sort of illustrating this again, if you go anticolic, which as again Dr. Marcel was saying is a more commonly used approach, now you no longer create this mesocolic defect through which small bowel can pass. So you really just have Peterson's defect right here to worry about, and then the JJ defect which is also routinely closed. When you create the retrocolic, when you pass things retrocolically, then you create a defect through which small bowel can pass. So if you have a suspicion of, really any obstruction, the typical pathway or work of these patients will include a CT of the abdomen pelvis. So I'm just going to walk through a couple of classic radiographic signs that are associated. These are, both buzzwords that will come up on tests, but also very clinically relevant things that you should be looking for in a CT of a patient with this or other anatomic variants that you might be suspicious of them having an internal hernia. So these are kind of some of the signs. This is one in which you have small bowel passing behind the SMA right here. So there isn't no small bowel outside of the duodenum, should be behind, going posterior to the SMA, and so that that's a classic sign, essentially affiliated with that. There's another described finding is this mushroom-shaped mesentery, in which your small bowel is again passing through that defect that's right here, and will generally head towards the left upper quadrant. And so again, if you have a cluster of small bowel in the left upper quadrant, that's also classically associated with an internal hernia, notably through Peterson's defect. And okay. And then there's the Mesoteric Swirl, which I think we've all probably aware of, but just sort of a twisting of that mesentery on itself. Again. So for these patients, again, I think it's hard not to overstate the fact that you should have a very low threshold to take these patients to the OR. Internal hernias is associated with high incidence of bowel ischemia, and ischemia that can really involve the entirety of the remainder of your small bowel. It's not involved in these fixed points, essentially, or these anastomoses that can then in turn lead to short-gun syndrome and TP independence for life. You can do these laparoscopically depending on the patient's hemodynamic status or the degree of dilation, but again, there's bowel typically isn't super dilated, and so just given that a lot of it's involved or a lot of it can be involved in the hernia itself and effectively decompressed. But classically, what's described is you want to start at a fixed point, and so in these patients, this consists of the terminal ileum. So you'll start the terminal ileum and then run the bowel in a retrograde fashion. This helps to reduce the hernia. And also can help because, at least in our case, it was twisted multiple times around this defect. And so just looking at the hernia itself, which is kind of natural inclination of when you're in there, it's kind of where your eyes go directly to. Sometimes it's hard to tell, whether or not that, you should be reducing in a clockwise or counterclockwise fashion, or how to, where that defect is. And so you'll start at the terminal ileum and just run the bowel in the retrograde fashion. And then effectively look, this, again, like I said, this will help to reduce these defects. And then you want to assess the defects themselves. So for the JJ, you'll move the roux limb onto the patient's right side, lift it up, and look for that defect, close it if present. And then for the Peterson's defect, you'll hold the transverse colon cephalad, move the roux limb to the left, and again, look for that defect and repair that with permanent sutures. Also, a major part of this operation is to assess for bowel viability. Obviously, if there's obviously necrotic bowel that needs to be resected, and depending on the patient's stability or other kind of clinical factors, may need to be maybe possible reanastomosis. But consideration should also be given for second look laparotomies or laparoscopies. Again, if the bowel hasn't really pinked up right in front of your eyes in the ED itself, or if you have kind of diffuse and ecumonic mesentery that's very very swollen and edematous, and so regarding this is out of the SAGES manual, but example port placements that they recommended for this is essentially you're mainly going to be working kind of in this area, typically on the left side of the abdomen, either at Peterson's or the JJ defect. And so they recommend placing your suprapubic port for your camera, 2 working ports on the right side of the abdomen, and then an assistance port on the left. And then well, I mean, yes, yeah. I mean, I guess. Sure, you can look. I mean, you'll be operating kind of awkwardly.
The nice thing about ports, you can switch instruments. I think the one thing that I'll throw the picture don't be afraid to move around and move the bed a lot, because that tilt makes a big difference where everything is fly.
Okay.
So if you use this port placement, that's right foot, because you don't want to have your suture in a lot of defect. You want to have it set up for that, but you're going to have to go to the other side and camera, the bed.
Don't be afraid to move.
Sure.
Yeah. I use my same port placement. It does make it hard to get but either way, if I were going to do it, I'd probably put another port on the right side. And, yeah.
That's right. Sir. And then to finish, I just have some videos essentially of examples of internal hernias reduction. So here, again, you don't, the second video is a little bit better for proper sort of initiation at the terminalium, but here you have them essentially reducing the hernia in Moss through the defect itself. So you're looking at Peterson's defect right there. They're just moving that bowel back into place. It looks viable. And then, so here you have the transverse colon here. And then obviously the rulum. And they're closing that with, again, non-absorbable sutures, so you don't run into this problem in the future. And that's the end of that one. And this one, you have 2 notable findings. So you have chylothorax here. This can cause a lot of, again, blockage of your lymphatic channels throughout the small bowel. That chylus perineum, excuse me. And so, that's also a more ominous sign that this has been going on for a while, and you'll have vascular congestion and effectively obstruction. As you can note, there's a distinct difference in the color of some of this bowel, more purple, turning darker than, sort of its pink sort of counterparts here, which is representative. This is actually the BP limb. So as I mentioned, they started they find the fold of Treves at some point. Yep. And then they just start at the terminal ileum, start running the bowel. At some point, you kind of see this one-to-one mobility of the bowel moving through the hernia, which is encouraging from a reduction standpoint. Eventually, they get it all reduced and find the defect here. So here they have Peterson's defect again. You have colon up to your left, rulum here, and they close that with running non-absorbable suture. And this is a small questionable defect at the JJ that they ended up closing as well. And here you just have here you'll note this diffuse lymphatic obstruction that again, can occur from this mesoteric engorgement and obstruction. And at the end, again, after reduction of that, of the hernia itself and closure of those defects, they take another look at the bowel and note the sort of distinction between the potential viability, and felt more comfortable closing in that situation. Our patient was left open actually, and taken back to the OR. She had she had a prolonged presentation. She had a documented internal hernia. She was transferred from the VA and probably from a day earlier, and had really diffuse like mesenteric engorgement and really thrombosis, ecchymosis, and so even after reduction of the hernia and closure of the defect, had some question about valve viability, and brought her back to the ICU, and then she was taken back and ultimately closed.